Are you curious about Gestalt language processing? You are not alone. Join me, Corinne Smoose, and speech therapy PD for our podcast, The Gestalt Get Together. Our episodes try to balance the enthusiasm and excitement about GLP and its associated intervention ideas, as well as a healthy dose of skepticism about how to understand and integrate this paradigm shift into your career and the field at large. We hope that you can get together with us to learn more about Gestalts.
Welcome to Brainstorms, Functional Neuro Rehab for SLPs, presented by SpeechTherapyPD.com. This podcast is designed for the adult medical speech-language pathologist. Most of our audience members work in settings such as acute care hospitals, private practice, outpatient hospital clinics, and inpatient rehabilitation hospitals. Each episode has an accompanying audio course on SpeechTherapyPD.com and is available for 0.1 ASHA CEUs. The content of this course is based on the research and experience of the presenters. The listener is responsible for researching to determine if the information and skills taught are appropriate for their clients, students, or patients. SpeechTherapyPD.com does not necessarily endorse, recommend, or favor the information shared, nor any of the claims, opinions, statements, offers, or services made by the presenter.
Hello and welcome, everyone. My name is Renee Garrett, and I am your SpeechTherapyPD.com podcast host for Brainstorms, Functional Neuro Rehab for SLPs. Before we get started, we have a few items to alert you to. Each episode is 60 minutes and will be offered for 0.1 ASHA CEUs. Here are the financial and non-financial disclosures. Dr. Yvette Hyter received compensation for this presentation from SpeechTherapyPD.com. Her non-financial disclosure is that she runs an online trauma institute. My financial disclosure is that I'm a paid employee of a private consulting firm in the Commonwealth of Virginia, and as the host of Brainstorms, Functional Neuro Rehab for SLPs, and other webinars on SpeechTherapyPD.com, I receive financial reimbursement. My non-financial disclosure is that I am the secretary for the Communication Disorders Foundation of Virginia. Questions can be written in the chat box or the Q&A and will be answered throughout the presentation. Now, without further ado, we welcome our guest, Dr. Yvette D. Hyter, PhD, CCC-SLP, ASHA Honors, Professor Emerita at Western Michigan University, also ASHA Fellow. She's focused on culturally responsive practices and has co-authored a textbook on culturally responsive methods. Her work also focuses on the impact of trauma on communication, language, and literacy. She co-directs the Resiliency Center for Families and Children. She owns Language and Literacy Practices, LLC, providing culturally, linguistically, and trauma-responsive, globally sustainable consultations and courses for educational agencies. She also has a forthcoming textbook on language research and post-traumatic stress and is a founding member of the SLHS Equity Action Collective, whose members established an open access journal, the Journal of Critical Students of Communication and Disability, and who are transforming scholarship, practice, and policy using critical science, equity, and social justice. Welcome, Dr. Hyter. So nice to have you tonight.
Thank you so much. It's good to be here.
So let's jump in because we met before and I really enjoyed our conversation. And, one of the things that I really took away from it was just the variability of trauma across the lifespan, because I know primarily you've worked a lot in the child language and literacy field, whereas I've worked primarily in the adult medical setting. But I feel like there's some intersectionality between all of this because so many people across the lifespan have experienced trauma. So what would you say is a good definition of trauma?
Well, I like to use the definition that it's an event or a series of events or experiences that leave a person feeling helpless or hopeless or a profound sense of loss. It can be really overwhelming. And it also is the ongoing impact that those experiences have on the life of somebody. So it's the ongoing impact on your perceptions, one's development. And Bessel van der Kolk, I love the way he put it. He is a psychiatrist who wrote the book. I'm blanking on his book, but I will remember it. It's a wonderful book. And he says, though, it is the imprint of an experience or event that is left on a person's body, brain, or mind. Mind, brain, and body, I think is the way he said it. So it's that imprint. And there are different types of trauma, too, that we can talk about. Should I?
Absolutely. Yeah, because I was just thinking about that as you were talking and thinking about, I did a presentation on trauma-informed care at ASHA last year. And that was one of the things that we talked about was how it's just not always something that is a direct event that happens to a person, but you can be a witness to it as well. But yes, please, for sure. Take it away.
Sure. I remembered the book. It's called The Body Keeps the Score.
That's right. Yes.
Yes. And so there's different types of trauma. There's an acute trauma. It's something that's happened once, like a car accident. I remember in the year 2000, I was rear-ended with a hit and run type of situation. Someone rear-ended my car. I had a minor concussion, but generally I was fine. But still, making a left turn without a light, I have this physiological reaction to it. And I know what's happening in my body. I'm thinking about that rear end. So it only happened once, but it can still affect you profoundly. That's an acute trauma. There's a chronic trauma, something like bullying that happens often and it happens over and over again, or like war. If you're fighting in war. There's complex trauma. That's the area of trauma that I have focused my career on. And that that's complex trauma is when something happens in the caregiving system. So it happens in the place or in the context in which you should feel the safest and the most safe. There's systemic trauma. We don't talk very much about that. But systemic trauma is that is sanctioned by the society. So think about impoverishment, or think about homelessness, racism, and other forms of systemic forms of exclusion, heteronormativity. All of these things can be traumatic to groups that experience them, but they're sanctioned by society because they are allowed to continue to happen. And so that would be called systemic trauma. Sarah Haynes, and I'm going to read this quote, who wrote the book, The Politics of Trauma. She writes that systemic trauma is the ongoing violation, dismissal of, or deprivation of groups of people. These are state institutions, economic systems, and social norms that systematically deny people access to safety, mobility, resources, food, education, dignity, positive reflections of themselves, and belonging. And this is all how she defines systemic trauma. There's also vicarious trauma, which you mentioned, is when you have not experienced something firsthand, but you witnessed, or if you are part of a trauma team, like I was for a very long period of time, and you're hearing these stories all the time about the traumas that people experience, and then that you can start experiencing some symptoms that is impacting your life just by hearing and being around that. There's also historical trauma, and historical trauma is often thought about in three different types. So there's a trauma, there's some kind of something bad, harm that has happened. And then it happens across generations. And then it impacts an entire cultural, ethnic, or racialized group. So think about 9/11. Think about, that's more like a collective trauma that's historical. Think about things like a genocide or colonization, enslavement. And the colonization also is an act of dispossession. So the colonization dispossesses groups of people of their language, of their culture. So all of that's kind of a historic trauma. And then there's the last one I'll mention now is the intergenerational trauma. Now, historic trauma is a type of intergenerational trauma. Intergenerational trauma crosses generations, usually in the same family.
Mm-hmm.
And so you've had some kind of trauma that might be affecting multiple generations in the same family. And I mentioned collective trauma. I think I did. Yeah, when whole groups of people are being impacted.
Well, and I think part of that, most recently would probably be related to pandemic. And that was so widespread because for first responders and people that were working in healthcare like myself, I think there were so many layers of trauma that we experienced. It wasn't one category, it was multiple categories. And that was the part that was so difficult. It's kind of interesting to me because I've heard the term like pandemic fatigue and people saying that they just don't want to hear about it anymore. They don't want to go to presentations on it. They don't want to hear about the longitudinal research, but it sort of feels in some respects how people that were in conflict and military were treated when they returned home and blamed for things that maybe wasn't necessarily their fault. That they were there doing their job and then experienced this trauma that changed the course of the rest of their life.
Right.
And it's not exactly the same. I'm just relating it as an example.
But I definitely would put COVID, the pandemic, in that collective trauma category, right? And other things like mass shootings. All of these collective experiences that we've had that leaves you feeling overwhelmed. That could be part of that trauma fatigue. You're just so overwhelmed. You just can't hear anything more about it. It's just one thing too much. And so it leaves you with this feeling of overwhelm, and some people are feeling hopeless or helpless. And the sense of loss that people experience, and some communities much more than others, right? So communities of people who are impoverished, or communities of color, immigrants. I know that we sustain so many more losses in the world, as a result of COVID. So that definitely is a collective trauma. And I can see the pandemic fatigue being this sense of overwhelm. It's just, it's just too much. Just one more thing. I just cannot handle one more thing.
Yeah. Well, and I think, again, there's so many different types and how they present in real life, whether it's people's abilities to respond or react, their generalized behaviors, and even like the social pragmatic pieces. And I know you're going to talk about each layer of that, but, thinking about how difficult it is still to talk about being a healthcare worker during that time. It's almost like you're getting it multiple ways because it's hard to talk about. But then when someone says, I don't want to hear about it, you're also like, oh, now I'm completely shut down. And so
Right.
it's such a, if we think about it beyond the COVID pandemic, but thinking about like I'm working with individuals with developmental disabilities, and a lot of them live in group homes and other community living arrangements. And so thinking about their lives and some of the things that they've been exposed to, and then, we're exposed to it when we're working with that population, reading the chart, it's multifaceted. And I think that's a really important point to make, because it doesn't just impact one person or one community. It just has so many layers and so many ripple effects across communities and across the world for who's impacted, and the differences in how it's impactful for those people.
Absolutely. Yeah. You mentioned,
So
I'm sorry.
No, I was just going to go back to the behaviors of how like it impacts people in real life and what those behaviors look like.
Yeah. So most of my experience has been with young children, school-age children, and have had some experience with adolescents, but I'm going to talk from that particular vantage point. But so I've seen some of behaviors are difficulty regulating behavior, for example. Children, I have a dear friend, his name is Mark Sloan, who is a pediatrician, and he really simplified an explanation of how regulation might look and dysregulation might look is using Winnie the Pooh characters of Tigger versus Eeyore. Now, if people who remember that cartoon, that the children that have really high levels, or I would say low levels of regulation or high levels of dysregulation, are sort of like the Tigger, right? Tigger was really bouncy. He would bounce on his tail. He would bounce people, run into people, body slam them. Very active, very moving a lot. You would see that in a classroom of children moving a lot, moving their feet a lot, up and down a lot, on the floor. I've worked with children who, felt needed that sensory input, so they would roll on the floor or roll on top of blocks. And so you have that, so that it might look like that in a classroom. Or you might have someone who is more like Eeyore, who is very low energy, head on the desk, just kind of moves really slowly, doesn't have a lot of energy behind their movements or interactions. In either of those on either end of the spectrum could be impacting the child's ability to attend to what's happening in the classroom, to engage in activities in the classroom. But in addition to those low energy, high energy behaviors, you can also see difficulty with problem solving or executive functions, making a plan, or figuring out, what happened that was a breakdown in this particular situation? What can I do differently the next time so that that doesn't happen? So having difficulty, doing that type of thinking so that you are planning and working through some issues that you might be having with other people. So you see difficulty with planning and problem solving. You mentioned also social pragmatic communication. People don't often think about the impact that trauma can have on our communication. And just think about, we were talking about, wanting to talk about our feelings, right? Or wanting to talk through something. When we have an incident or something that happens to us, it's natural as humans to want to tell someone about it, to talk about it, tell the story. You're recounting this event or something that happened. But what happens when you're under high levels of stress, your brain, and you're in this constant stress feedback loop in your brain, the stress hormones are continuously firing, your amygdala is continuously fired up, and the amygdala you're in fight, flight, or freeze mode, it kind of sends a message to the hippocampus saying, we're not going to write any new memories right now. We have to survive. We don't have time to remember everything or to write the memories. And hey, prefrontal cortex, we're not planning either, right? We are trying to survive this situation. But when your brain is in that constant feedback loop, what happens is that it fragments memories. And so when you have been traumatized and you're trying to retell or recount something that happened to you, it is difficult. You may not have all the pieces. You may not have all the sequence. You may not have all the memories of everything that happened, even if it happened to you. So it impacts your autobiographical memory and your semantic memory, your memory for just remembering what things are and how they're used. And so it impacts memory. So you might have, what I do know about individuals that have traumatic histories, is that they have difficulty with theory of mind, understanding why people do what they do. They have difficulty with perspective taking, being able to see things from other people's points of view, and have difficulty with, I mentioned the memory, emotional memory. So this, the emotions that you had at the time you had this experience can come back on you. We call it triggering. You can be triggered even if you're not in the same context, a smell, a memory, a feeling, a color, something reminds you of a traumatic experience, and then you can be triggered with that. You might be very overly sensitive to touch or to sound or to colors, certain colors. But one of the most profound things, I'm pretty sure I've told this story, and your audience might have heard me tell this before, that really just put an underscore for me about how essential it is for speech language clinicians to be involved with individuals that have trauma history, is when there was this child who was recounting, he was on giving a testimony in court about some abuse that happened to him, but the judge didn't believe him. Why? Because the child's story was fragmented. It wasn't complete. Sometimes, it sequenced one way and then he would retell it and it would sequence a different way. There were pieces that were missing, and the judge didn't believe him it took trauma experts to get on stand and explain why the child's memory wasn't as clear, even though those things happened to him, that child, that there are issues with being able to tell your story, which is also essential for healing, right? And who are the experts, right, that can help with narrative, can help with conversation, would help with perspective taking and theory of mind, right? So it's just, it's kind of like, this is like, we just have to be involved here. And so those are some of the, getting back to your main question, those are some of the behaviors that you will see. And I've particularly seen them in adolescents and in children, school-age children, and in preschoolers. It also affects play, the ability to engage in social interactions, to acquire new friends, to maintain those friends. It affects all levels of development and all levels of interaction. So, and, of course, it can be variable. Not every child is affected in the same way, but these are some of the behaviors that you can see.
Well, the interesting part for me is that when you're saying this, it's very similar to the work that I've done with patients with traumatic brain injury, post-concussion syndrome, because it's very similar. A lot of the time, the first thing, especially when I was in acute care working in trauma, people wanted to recall the accident when they were, out of the immediate ranchos, 2, 3, 4 levels. They started to become more aware of something had happened and they want to recall it. They want to be able to tell you what happened and they can't. And I always would say the same thing, that, your body was focused on staying alive, not on recalling what happened to you, because that oftentimes is so devastating that your brain is protecting you from that by not imprinting new memories. And then the other piece is that, again, that's very similar when we're relating things across the lifespan, is that trauma imprint for those patients who have had these traumatic things happen, whether it's a domestic abuse situation, a motor vehicle crash, gunshot, any of those traumatic things that can cause, multiple wounds, but traumatic brain injury and, attribute to things like PTSD, is that they oftentimes have very similar things happen. We used to use this term confabulation a lot for TBI patients, that they would make up stories and it was confabulation, but it wasn't necessarily that it didn't happen. It was they were all out of order and all out of sorts. And so it was like this big pot of stew with all these ingredients, but the ingredients are already in there and they're now trying to extract these memories out to recall and retell. And like you mentioned with the I can't talk today, judicial system, is that it's difficult because a lot of the same thing with traumatic brain injury and other accident survivors, it's that sometimes they get called to the stand to testify as well. And they can't recount what happened because pathologically it's just not possible for them because of what happened. So, we have in Virginia, we have through the Department of Health, we have a program called Virginia Heals that is free trauma training. You don't have to be, in the state of Virginia. You can do it from any state. And it's not super intensive or anything like that, but it's a very good overview of how to be a provider with basic trauma-informed knowledge. And you can do a really quick course that teaches you how to screen and what kind of screening tool you can use.
Are you taking advantage of our new amazing feature? The Certificate Tracker. The free CE Tracker allows you to keep track of all of your CEUs, whether they are earned with us at speechtherapypd.com or through another provider. Simply upload your certificate to your registered account and you're all set. So come join the fastest growing CE provider, speechtherapypd.com.
And I think whether you're working in the pediatric or adolescent age group or the adult, it's helpful to have that knowledge because it's not something that we come out of, our CSD programs having a good experience or a good background in. But kind of circling back to what you were talking about between trauma and memory, when you're looking at the micro and the macro level of that, what kind of things do you think are important to note?
Well, thanks for bringing that up. The micro level, I'm thinking about that's the individual person, right? So we've talked about how trauma can fragment memory. It can shut down your autobiographical memory, it fragment those sequences. It prevents us from combining concepts to make a semantic memory to remember what things are. We can be triggered, so these memories can interject themselves into our minds, and without even outside of the context, without our planning it or expecting it. So that can happen on the micro level. But on the macro level, which is where you have this collective memory, I have this book called Colonial Trauma by Lazali, which was written in 2021. And that author talks about the impact of collective trauma like colonization, which is dispossession of the land, the language of a culture, and the impact that can have on memory. And specifically, he says in one of his chapters on page 71, he says that the political order determines what gets remembered and what doesn't get remembered. So if you think about it, even just using enslavement as an example or colonization as an example, the people or the groups with power determines what's important to be written, to be recorded, to be told. And there's even a movement now, right, to rewrite or to expunge some of the history of groups of people from state curricula. And so that is happening today in 2024. But this politics, this access to power and the ability to be able to make decisions within your own can determine what gets remembered and what doesn't. So as a collective group, like people who had a collective trauma, we were talking about COVID earlier. I'm just giving this example. So let's say if there's COVID and then groups of people who had lots of influence over the media decided they were going to say that COVID was nothing, right? That it really didn't happen and no one really experienced it. And so they would have decided, what gets remembered, which and that disabling memory of the group of people who were affected really gets, I don't know, it gets bottled up. It's not able to be processed. And so that also interferes with movement forward or a group's healing. So disabling memory, dispossession of memory is also a colonial project, right? And so it's still happening. We may not call it colonialism anymore, but it's still like changing history, changing people's stories to fit a certain narrative is also a real danger of, or the connection between collective memory and trauma.
And I think too, that goes back to the concept of the reactivation, because for those groups that you've mentioned, being dismissed and being unheard and unseen, it reactivates that memory that is now being disavowed, if you will.
Oh.
And it's very, just speaking from my personal experience, because there were friends that I had for long periods of time who, for lack of a better word, they couldn't handle it. They didn't want to hear what was really going on. And so they just kind of disappeared. And that leaves an imprint on you too, even if you are an adult. It's very, it does, there's certain things that happen now. And you mentioned a car accident earlier. I had a car accident many years ago where I was car 3 of 5. And so someone hit me from behind and pushed me into the car in front of me. And so I'm always looking in the rearview mirror all the time. And when I see someone getting too close, I'm like, you just feel it. You feel that embracing, you're ready, well, not ready, but you're like reliving that experience. And it's just so interesting to me to think about how that goes across the lifespan, because it's not, I think in many respects, we try to compartmentalize things. And so we put people into boxes, right? So we've got our kid over here with autism, and they've got autism. Then you've got, for me, like I have several patients that are my IDD clients who they have multiple diagnoses of IDD and autism and maybe cerebral palsy. Maybe they also had some abuse in the home that removed them and put them into a community living setting. And then it's always remarkable to see that the caregivers don't always understand that this isn't one thing and this is one thing and this is one thing. They all interplay. And so that's a really interesting piece, I think, too, in relating again across the lifespan of how that childhood trauma continues to
affect you.
Yeah, be present.
Yeah.
And you mentioned the social pragmatic communication. And I think that for me is so interesting, because a lot of times what winds up happening is these clients get labeled as nonverbal. Yeah. And I just had a guy last week that I went to go see who gets labeled as nonverbal. And when I got ready to leave, I looked over at him and I waved and I said, "You're doing a great job with your puzzle. I'll see you next time." And he goes, "Bye." We made an effort, right? I made an effort to speak to him directly and not talk about him if he wasn't there.
Exactly. Yeah.
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 So is there specific training for CSD professionals that you feel like is just important to mention, but when you're thinking about the trauma-informed care piece?
Sure. I mean, I think there's more and more that's cropping up. I did take a look at the Virginia HEALS. I appreciate that. I'm glad that exists. And I think that information like that is helpful. There's a group out of Toronto, Canada, the George Hull, Hull Center. It has some trainings online. And then I have you mentioned the institute that I have, which has some modules, which are pretty introductory, but still, if you're looking for a place to start. And then there are some new things. I'm not sure if people are attending ASHA or not, but for the first year, this is the first year that ASHA has a topic committee called Counseling Trauma-Informed and Contextualized Care, which I'm very excited about. I'm serving Yeah, I'm serving as a co-chair of that topic committee, and we have received several proposals. Of course, we don't know how that will shape up because the review of the proposals hasn't taken place yet, but it's a topic that's growing. So there will be presentations. We have 4 invited presentations that we'll have there at ASHA. One is a 2-hour course, and then the other 4, I think they're 5 sessions, are 1-hour sessions, but they all focus on counseling or trauma or some kind of combination of that. And so those are some good things to, tap into. There are some good, really accessible texts. There's one by Naame Yehuda, Yehuda, and her book is called Communicating Trauma. She has the only book level treatment of trauma and communication that is written from a speech language clinician. She uses a lot of examples from her private practice. So, that's a very good introductory book. Trauma keeps the body keeps the score. Bessel van der Kolk, that's another really accessible, it reads really easy. It's easy to read and understand. Nadine Burke Harris has a book called The Deepest Well, where she talks real in depth about what happens in the brain. Trying to think if there are others. So there are a lot of things. There's some special issues of journals, SIG 1 special issue. There's one that came out in 2021. There was a special issue in 2007, which is very in language, speech, hearing services in the schools. So there's some things that you can put together to create a course for yourself about trauma. And there's more and more coming on the scene. What you won't find, which is really unfortunate, but a good time for people to start doing some things. You won't find any evidence-based studies in speech language hearing about trauma-informed practice because there aren't any that have been published yet. Yeah. I'm sure there's some doc students or master's level students who are just dying to do a thesis or a dissertation on that topic. So I hope you will, because we really need it.
So someone asked in the Q&A if you could repeat the SLP written book again.
Yes, it's called Communicating Trauma. And the person's name, the author's name is Naama, N-A-apostrophe A-M-A. And her last name is Y-E-H-U-D-A.
Y-E-H-U-D-A. Communicating Trauma. Okay.
Communicating Trauma.
Okay. Thank you.
Yep, you're welcome.
Well, and one of the resources that I came across a couple times when I was looking at different things was Oregon also has training on trauma-informed care, and it's traumainformedoregon.org. And they have different training modules. It's not just one thing or like one course or whatever. There's several different training modules. And I can't remember each and every one of them, but they get specific into the different types of trauma, and then resources it's not just for speech language pathologists or audiologists, but also for teachers and people in the, different people in the classroom. And I know that they are called different things. Like here, it's usually a resource aid or something like that, I think is their title. But then we're also starting to have SLPAs more and more. I know in some states they've been in the classroom for a very long time. And so it's helpful for that group as well. And again, I think anytime when it's free, but it's, as I like to tell my students, a scholarly or supported by an organization that is out there doing, like departments of health and things like that, who are out there doing
Right.
those community resource works, I think is a good avenue to explore. The NCTSN too is another one, National Child
Right.
Trauma Support Network, I think is what that stands for.
Uh-huh. Uh-huh.
They also have some e-learning courses that are available.
And SAMHSA has lots of resources, Substance Abuse and Mental Health Services Agency, like NCTSN, they have lots of resources. They also have a little booklet that you can download about trauma-informed care. So it defines it. It talks about principles of trauma-informed care, principles like the culture of safety and comfort, providing, real choices and giving clients opportunity to use their voice to make decisions on their own, collaborating across disciplines, as well as collaborating with I'm using client, but I really prefer not to use that word, like your clinical partner, because, we want to partner with people that we're working with. Another principle is transparency, which builds trustworthiness, and then being able to recognize practices that you're doing that might be re-traumatizing. So, looking at what are you looking for? What does re-traumatization look like? And what might some be practices that I'm involved in that might re-traumatize someone?
Yeah, and I know the Virginia Heals in particular, they talk about reframing the question or reframing a statement where you can maybe gain access to the information that you're looking for, that you need to better inform your practice or your care for this person that you're working with, whether it's a child or an adult. Because I think, again, depending on where you live, there's some regional language that's accepted or widely used that maybe isn't framing the question or the statement when you're dealing with the public or in a public health kind of environment. Because I think public health really, that can be educational. It can also be in the hospital setting or in the group home or community living setting. And so being able to reframe and just practice that, reframing the question or reframing the statement so that it's not re-traumatizing or kind of reactivating that memory that's, can be very unpleasant.
Right. One of the things that I like to think about it as thinking about not the deficit view, but a more of a strength base. So you're trying to think about what words will be more strength or giving life as opposed to deficit or like bringing down, right? So if we're thinking about, see if I can think of one off the top of my head, but just trying to thinking about the words and the way that we organizing our practice so that it's more focused on what people bring to the table, all that they bring, and not what they may not be bringing. And reframing, and I'm just picking up where piggybacking on you, Renee, but reframing how we're thinking about behaviors too, right? I think that's really important. When we started working in schools in the year 2000, there was a lot of focus on willful disobedience. So children were considered to be willfully disobedient. He could sit still if he really wanted to. He doesn't need to be rolling on the floor like that. It was always, they're doing it because they're doing it deliberately. But what we were able to help teachers do and school staff is really kind of reframe their thinking about that behavior. That no, he probably can't sit still, right? Physiologically, he can't do that. So, how can we help them pay attention, even though we're not looking at it as willful disobedience, that we are looking at it as this is a response to a trigger, or this is a response to feeling overwhelmed, or he's dysregulated or having difficulty focusing. So how can we support getting him more focused as opposed to demeaning him because he's not doing what we think he should be doing in his seat?
Well, and
Right.
and if you think about that, just in in the classroom in general, take away any kind of language disorder or any traumatic events that may be impactful for someone with a special need or a neurodivergence or whatever. How many 6-year-olds, 7-year-olds, 8-year-olds, how can you expect them to sit for 6 hours and never speak to their neighbor and never go to the bathroom and never get a drink of water? It makes zero sense. I
Right.
can't do that, and I'm a grown up. Well,
Right.
most days I'm a grown up. I think, kind of talking about what you were saying with, the kids used to get labeled as bad, or they're disruptive in class, or they don't have rules at home. And there's all these other things that, I've heard come up on the parenting side of it as a parent. And I think about it now differently as a clinician. And again, I don't work with kids, but it makes so much sense with these other populations that I work with, medically complex and traumatic brain injury. And, how do you expect anyone to uphold these unrealistic standards? And then you wonder why they're doing these behaviors. They're tired, they're thirsty, they're hungry. You go back to Maslow's hierarchy of needs. And I think you mentioned this early on: food, safety, shelter.
Right.
If those 3 things aren't being met, you don't feel safe, you're hungry, and you feel out of sorts because this isn't your regular environment. And you think about those traumatic events that have placed someone in a hospital that's different from the norm. We can relate that to kids who have been displaced, who are houseless, or maybe have been in the system in foster care, and now they've been moved from place to place to place. We can also relate that to our patients with dementia or other disorders who live in long-term care facilities, and they come to the hospital, and I'd get the report from the nurses and I'd be like, good luck with that. They're just difficult. Well, no, it's different lighting, it's different smells, it's different food, different sheets. The room is set up different. When you think of it from that perspective, it is trauma-informed care. And we're looking at, what does our mindset need to look like so that we can communicate that to the staff, as well as having it in our own mindset when we go in to work with different people across the lifespan, because that's the bottom line, is it's everything that's different that throws someone off. And this is one of my favorite things, is that's why the people at church, that's why we sit in the same pew every week.
Exactly.
You get mad if a visitor's in your seat because that's your seat.
And you're standing there thinking, okay, now what am I going to do? Like, where do I sit? You're trying to figure it out.
Yeah. And we don't, I think we would like to think that instinctually we should know that. Definitely as professionals, we feel like when we hear it, it all makes sense, but we're not trained that way. We're trained in a lot of different areas, and the expectation is that we're good at all these things, and we should just know all the things and stuff. But I think, and you and I talked about this a little bit, having this as a component of the programs and universities would be so helpful, because it's not right now. And so, are there strategies for CSD students or speech language hearing science students that you would suggest that may be able to have them come out of the gate more prepared?
I think one of the things is really, I would start with those principles of trauma-informed care. I mean, this is something you can find online through SAMHSA. You just type it in, principles of trauma-informed care. I'm sure the SAMHSA brochure will come up. But then working with others, and I say working with others because I'm a big proponent of needing to collaborate. And it's just, when you have multiple people thinking about something, it's just more clear and it's easier. But if you're, working with a group of other clinicians, thinking through your own practice, what you do or what you don't do, and how they meet or don't meet those principles, And then let's take safety, for example, a culture of safety. So all of us would probably say, my clinic room is safe. My office is safe. I am a safe person, right? But who knows that best? You. The child or the adult that you're providing services to, meeting you for the first time, they have no idea that you're safe. But what's safe really has to be based on how they define safety, how they envision what safety is. And, some counselors will ask the adult, tell me what's comfortable for you, right? And the adult often can say, this is comfortable for me, or I don't like this, or I don't like that. It's different when you are working with children because they're not always able to identify what makes them feel safe. And two, they're also not always brave enough to just say what's on their mind when they're talking to another adult. And, sometimes there's cultural things involved there. So, it may be appropriate, may not be appropriate. So, kind of thinking through, how do you work with individuals on your caseload to help them identify for themselves what would make the space a safer environment. So I think if they take, it's kind of like a self-study. You just take that, looking at those principles, start with the first one. How does my practice exemplify safety or comfort? How might it not? How might I collaborate or partner with this person on my caseload to identify for them what could be different or what make it feel more safe in this space? And then just do each of those. I think that would be a good first, step that someone could take. I mentioned some of the reading, but I also think if you are practicing, to try to build a virtual transdisciplinary team. Now, maybe it's not transdisciplinary because you may not be able to work on everything together. People might not even be in your same location or in your same institution, but building a network of people with whom you can have reflective conversations and learn from. I think that's also important when you're trying to implement new skills into your repertoire and new information into your repertoire. Then, working with others to identify where the gaps in your knowledge and how you all can work together to help try to fill those gaps. And if it's across different disciplines, that's even better because a psychologist, a social worker, occupational therapist, speech language hearing person, a pediatrician, all these different disciplines will have different areas in which they are experts, but will be what can also challenge us to help us recognize, like, wow, that's a big gaping hole in my knowledge or in my practice. And often, we think that these teams have to be, or these partners or these learning partners have to be in the same institution that we're working in. They really don't. Go find a mentor at a conference. Find, make connections, go to a conference or look up someone's work that you admire and send them an email and ask them some questions.
I think that's how I met you.
Yeah, I mean, people are all too happy to talk about their work, right? So
Well, and
it's so
again,
wrong,
when
really.
you're looking at that trustworthiness and transparency component too, I think, whether that's interpersonal or interprofessional relationships, it comes into play again, not just with the patient or the student, but that caregiving team, whether that is direct service providers or family or parents or whatever that looks like, neighbors, whoever is helping in that person's care, because again, that safety, to me, that those first two, the safety and the trustworthiness and transparency, really interplay quite a bit. And even thinking about with the student, like graduate students and undergraduate students in our field, those relationships for collaboration in the future and empowerment really begins at that level. And I tell my students that all the time, not to burn bridges, because you may not want to go get coffee with that person or have dinner, but you never know. It's a fairly small world in some respects when it comes to speech, language, hearing, and audiology. We tend to wind up meeting people in this most interesting places and spaces sometimes, and then you wind up being interviewed by someone, or like in my geographical area, we have two pretty large CSD schools. We have 6 total schools in our state, and now we're going to have 7 with Dr. Miller opening up the program at Shenandoah in the fall. And so, it's a small world in one state to have 7 schools with that many programs.
Wow.
And you just never know. You could be in like our state organization has a student committee who does some supportive things for the conference and things like that, but they also work together on different community support projects and education. And that starts there with that. Okay, I'm in this safe space as a student that I can talk to my peers and develop this trustworthiness and collaborate and learn those early skills. So I think that's another really good place to start with our speech language hearing students, because you never know who you're
That's
gonna
right.
run into and who you're going to sit across the table from when you're looking for a job.
Right. Right. Or need some support for, a case that you're working on, or
Absolutely.
yeah.
Absolutely. Let me check the chat box real quick and just make sure we don't have anything that's popped up.
Okay.
Usually I see it right away. No, the last one was just that introductory module, and I put the virginiaheals.com. And again, it's free. It may not give you everything that you need, but it gives a really good start. And again, I like that one that Oregon has, because they
Can
do
you
the
say the name of it again? Oregon.
let me go down. I have the website, traumainformedoregon.org.
Okay.
Yeah. And they have different trauma-informed training modules. And I think they're specific to, I want to say the last time I looked, they had specific to age groups, but I think they also had specific to different occupations, like education versus healthcare and stuff like that. And they may have updated, because it's probably been at least a year since I've looked at that. But at the time that I was looking at it, it was another good place to start. And again, anytime you can get a free resource that's reputable and has that backup of research, I think is helpful for us, because a lot of times people will, have a lot to say about having to pay for things. Really, you never know. It could be something that comes down the line for state or even ASHA requirements at some point.
At some point. I think the acknowledgement of starting to talk about it in a formal way through the topic committee is a nice start. Not far enough, but it's a good start. And I think
it's a great start.
Yeah. And as someone who's been working in this area since the 1980s, it just feels, I'm really at the end of my career, and I just feel like we just come on. We need to move. But, so we are moving. It's just not as fast as I'd like to see it.
Yeah. It seems like everything takes time, and it's not always it's not our timing. That's for sure.
That's true. That is true.
And to be honest, coming from healthcare for so many years, it was when I first started looking at this, there were a lot of practices that I felt like I was doing a decent job at, and that made me feel better about what I was doing. But then I was looking at, as a team, when we're looking at a team approach, some of the things that we were not doing that weren't being delivered across the board. And I think for me, that was the really eye-opening piece, is to make sure that we're sharing this as much as we can, so that like you mentioned, different professionals bring a different perspective. And right now, I've always worked with OT and PT throughout my career, but right now I'm working a little bit more with behavioral therapists. And so that's been eye-opening to see their perspective, because a lot of that stuff that's focused on the old, I say old because I feel like I'm old, but the ABC, antecedent, behavior, and consequence. And that's so true when you're looking at a lot of the behaviors that you see, again, in these populations that we've mentioned. But I don't see any questions in the chat box and in the Q&A. But Dr. Hyter, I just want to thank you so much for joining us. I think this was a very informed conversation, and I appreciate you bringing so much of your expertise. You definitely are someone that I've looked into your work, and I really admire what you've done and what you've accomplished. So thank you for laying the foundation for future us as speech language hearing professionals. I really do appreciate that.
Sure. Thank you so much for having me. This was fun. I appreciate it.
Good. I'm glad you enjoyed it. Thank you again, and I look forward to seeing you again.
Thank you. Bye-bye.
If you have indicated that you are part of the ASHA registry and entered both your ASHA number and a complete address in your account profile prior to the course completion, we will submit earned CEUs to ASHA. Please allow 1 to 2 months from the completion date for your CEUs to be reflected on your ASHA transcript. Thank you for joining us at today's podcast. Remember to go to speechtherapypd.com to learn more about earning ASHA CEUs. We appreciate your positive reviews and support and would love for you to write a quick review and subscribe.